Okay, again, for those of you who may not recognize me, my name is Michael Purdy. I'm your instructor for this EMR class. I will be presenting the bleeding shock and soft tissue injuries lecture to you today. This is chapter 14 in your textbook. Please do go back and review the content in your textbook for chapter 14, as we are not going to cover it all here today in this lecture. This is more of a review to get you started, and some personal insight as well, and an explanation. Chapter 14. So this involves damage to internal or soft tissues and organs that cause life-threatening conditions. Some of those include internal bleeding, which results in shock. Shock is a state of collapse of the cardiovascular system that results in inadequate delivery of blood to the organs. So various reasons cause this, but for whatever that reason is, which we will get into later, the organs are no longer being perfused and oxygenated because of this state. More trauma patients die from shock than they do from any other condition, and this includes the actual initial point of injury, or what caused them to be injured. You should be pretty familiar with this by now, but just to review, we need to follow the steps of our patient assessment sequence. This always starts with our scene size up, including our dispatch comments or information, our windshield survey of the scene, scene safety considerations, what kind of additional resources we might need, things like that, followed by your patient assessment, or your primary assessment, I should say, sorry. And remember, during your primary assessment, this is your what's going to kill them in 60 seconds or less. You may need to pause that assessment to address a life threat, mitigate that or manage it, and then continue on to your history taking, and then your secondary assessment, and then reassessment. Also remember, just going back, for your secondary assessment and history taking, when we're talking about trauma patients, you may have to reverse those to manage the patient a little bit more effectively or efficiently before getting your history gathered. Always be alert for signs and symptoms of shock from internal or external blood loss. When the patient or when performing a reassessment, watch the patient for the following signs and symptoms of shock. Some of these, the most common, are pale skin, increasing pulse rate, and decreasing blood pressure. I'm going to add in probably one of the more common ones is altered mental status, or a change in their mental status. And that would actually be one of the earlier indicators that a patient may be going into shock. So the standard precautions in soft tissue injuries, this is the concept of standard precautions that assumes that all body fluids are potentially infectious. If it's wet and sticky and not yours, keep it off of you. Wear your gloves. You never know when something a situation might become potentially infectious, or you get some kind of bodily fluids on you. Take the appropriate measures to prevent contact with patient's body fluids. Wear gloves, wear a surgical mask, and eye protection if necessary. In the context of pandemic, consider the need to protect against airborne or aerosolized infectious threats. You may need to don a gown or a Tyvek suit, upgrade your surgical mask to a N95 respirator. Some cases you may even need to go a little bit higher than that. You may need to wind up using an SCBA or something of that nature as well. So just to review parts and functions of the circulatory system, the pump that we call otherwise known as the heart, it functions as a human circulatory system pump. So this is what actually makes our blood go round and round throughout our body. The heart consists of 4 separate chambers. We have our 2 ventricles and our 2 atrium, left and right. The 2 upper atrium chambers are on the top of the heart. The 2 lower, the ventricles, are on the bottom of the heart. So here are some of the main points of the heart to remember. You have the superior vena cava, the aorta. The aorta is where the blood comes out. The vena cava is where the blood comes in. You have the left atrium, pulmonary valve, left ventricle, right right atrium, pulmonary, and then the right pulmonary artery. And then, of course, the inferior vena cava. This is where the blood goes down towards the bottom of your body and coming out of the heart, and the superior is where it goes towards the top. The pipes, this is what carries the blood actually around throughout our body. We have arteries, which are carrying typically, except for in the pulmonary or the lungs, arteries are carrying oxygenated blood throughout the body to the capillaries, and the capillaries form a network or a web that distributes the blood to all the parts of the body and exchanges the gases in those capillaries. And then we have veins, which carry our deoxygenated and denutrient or nutrient-free or depressed blood back to the heart and the lungs. The only time that this is actually reversed is that the pulmonary arteries are carrying the deoxygenated blood from the heart into the lungs, where the gas exchange happens. The blood picks up oxygen, goes into the pulmonary vein, which has oxygenated blood going back into the heart. Everywhere else in the body, arteries have oxygen, veins have less oxygen or are oxygen depleted. So fluid, the fluid part of our of blood is called plasma. Our red blood cells that we have in our blood carry the oxygen and carbon dioxide. They are our transport vessels. Our white blood cells consume bacteria and viruses to combat infections in the body. And then our platelets are kind of like our internal Band-Aids. They form our scabs, our clotting factors, and help stop bleeding. A pulse, this is the pressure wave that is generated from the ventricles contracting and pushing blood out into the arteries. So that is what we feel every time you feel for a radial pulse or a carotid pulse. That is the result of the ventricles contracting and squeezing that blood out into the system. In most conscious patients, you can easily find that pulse in the radial wrist pulse at the base of the thumb. There are, in the medical field, of course, always variations or exceptions to the rule. There have been times I have not been able to, for the life of me, feel a pulse on the patient's left wrist, but feel it perfectly fine on the right. There may be a medical reason for that, and you can ask the patient if that's a normal thing for them, or if it's something that you need to take note of during your assessment. If the patient appears to be in shock or is unconscious, go ahead and attempt to locate the carotid pulse first, and don't really waste time going for those distal pulses. So shock. Remember that shock is defined as the failure of the circulatory system. Circulatory failure has many possible causes, but three of the primary causes that we're going to address here is pump failure, better known as heart failure, pipe failure, where there's something wrong with the arteries where they can no longer maintain blood pressure, and then also hemorrhage or fluid loss. Now, fluid loss doesn't necessarily have to be from hemorrhage. It can also be severe dehydration. And there's also other causes as well. So cardiogenic shock occurs when the heart cannot pump enough blood supply that the body needs, or to supply the body's need. The pump failure can result from a heart attack. Inadequate pumping of the heart can cause blood to back up in the vessels in the lungs, resulting in congestive heart failure. Okay, and we also have two different types of heart failure. We have left-sided and right-sided heart failures that have different manifestations as well. Pipe failure is caused by the expansion of capillaries to as much as 3 or 4 times their normal size. The blood pools in capillaries, and then the rest of the body is deprived of the blood that it needs. Your blood pressure falls, and ultimately shock ensues or results. So talking a little bit about shock induced by fainting, also known as psychogenetic shock. This is fainting is the body when fainting is the body's response to a major psychological or emotional stress. You'll see that sometimes that people will faint with the sight of blood, and that's just a psychogenic shock. As the nervous system reacts, the capillaries suddenly expand dramatically, and then the fainting is a short-term condition that corrects itself once the patient is placed in a horizontal position, and it enables the body to come back to a state of homeostasis. So pipe failure, we see this a lot in anaphylactic shock. It is caused by an extreme allergic reaction to a foreign substance that has been introduced to the body. The patient will generally appear flushed, breathing may become difficult, and then also their blood pressure will drop very quickly. Of course, if we don't take prompt action with our treatment, death often will take place. We also have septic and spinal shock. Septic shock, this is leaky or porous blood vessels that dilate due to an overwhelming infection throughout the body. It is a life-threatening emergency which often occurs in older adults, typically from things like urinary tract infections or some other kind of systemic infection. Spinal shock, also referred to as neurogenic shock, may occur in patients who have sustained a spinal cord injury. The injury allows the capillaries to expand, and then blood pools below the level of injury. The brain, the heart, the lungs, and other vital organs are deprived of the blood, resulting in that shock as well. Hemorrhagic shock, this is where we lose fluid from our body through hemorrhage or excessive bleeding. The blood escapes through a wound, and the system's total blood volume drops. So we hemorrhage, or we're having massive blood loss. The heart begins to pump faster to maintain pressure in the pipes to try to keep up for that volume loss, and then the blood eventually stops pumping and results into cardiac arrest when the heart has nothing left to pump into the system. External bleeding is not necessarily difficult to detect when the body is exposed. So when we're doing our trauma assessments or our rapid trauma assessments, we need to expose the body, especially in wintertime when people have multiple layers, big fluffy jackets and pants, things like that that can hide blood loss. We need to be able to see that. If we can see it, it's pretty obvious to determine what's going on. With internal bleeding, we can't necessarily see that bleeding, but you can see some of the results of the bleeding. We want to look for bruising, any kind of swelling or rigidity, firmness of a specific area, and then also severe pain in the immediate area around that where that hemorrhage is occurring. Whether the bleeding is internal or external, if it remains unchecked, that will ultimately result in shock and then pump failure and eventually death. Sometimes it happens in rapid succession. Sometimes it's a little bit more delayed. So an average adult human carries or holds about 6 liters of blood, as depicted in this picture here. The little jars represent a pint. A liter is 2 pints of blood, so you can kind of have a reference there of how much blood we actually hold. If you start taking your Nalgene bottle and considering how many Nalgene bottles of blood we have in our body, start taking those away, you can see how rapidly our volume decreases and we lose our ability to circulate and perfuse our vital organs. So as shock progresses, the body alters the way it functions in an attempt to maintain sufficient blood supply. One of your first signs and symptoms, primarily up front, is going to be confusion, agitation, restlessness, or anxiety. That's your altered mental status or your change in responsiveness. That's going to be your first indicator. Everything else that follows is actually kind of like a supportive factor. You can be altered for many, many, many reasons, but you start throwing all these other points in, it just kind of builds the case for, okay, this person is in shock. But following cold and clammy, sweaty, pale skin, shallow and rapid breathing, a rapid, weak pulse. Initially, the pulse will be strong because it still has the volume. It's speeding up to keep that pressure maintained, and as the volume depletes, it begins to get weaker. Increase in capillary refill time, we're going beyond that 2-second capillary refill time that we're looking at. We're up in around 4 to 5 seconds now, even longer sometimes. Nausea and vomiting, weakness and fainting, and then excessive thirst. People will begin to feel extremely thirsty because the volume in their system, their body is pulling fluids from their tissues and putting it into the circulatory system to try to help maintain that volume. So that's why they start to feel excessively thirsty. So we want to position the patient correctly. If the patient has no head injury or extreme discomfort or difficulty breathing, we can lay them flat on their back and have on a horizontal surface. That decreases the demand on the body to perfuse all other parts of the body and have to fight against gravity. It allows the blood to kind of stay more in the vital organs area. We want to maintain our airway, breathing, and circulation, and then treat the cause of shock if possible. One of the biggest treatments that we can provide, especially as an EMR, is temperature regulation. We want to conserve body heat so we can keep them warm in our treatment for shock. Oxygen is also a good thing. Also, very paramount is controlling that hemorrhage. We don't want to allow them to eat or drink. Eating and drinking can cause vomiting, which would cause an airway problem. So we want to avoid that. And then also, if the patient does have to go to surgery, they prefer that they don't have anything in their stomachs for that aspiration purpose as well. If you're trained to administer oxygen, you can provide that for patients that are in shock. Advanced EMTs and our paramedics will be able to introduce or initiate IVs and administer IV fluids as well. In some counties, paramedics can give whole blood as a volume replacement and actual blood replacement as well. And then we want to go ahead and start preparing our patient for transport and movement and be able to assist in that when the time comes. So remember, heart failure or pump failure is a very serious condition, and it can go downhill very quickly. Proper treatment and prompt transport by an ambulance to an appropriate medical facility will give these patients the best chance of survival. Pipe failure, anaphylaxis, we need to transport them as soon as possible and treat them even sooner. Some patients may carry an EpiPen auto-injector on them. Assist a patient if your local protocols allow you to, and you have been trained to do so. One of the big things, easiest things, is ask that person or ask a bystander if they have an EpiPen or if they have a known allergy. That's a good indicator that they may have one on them. So to do this, we will support the patient's thigh and place the tip of the auto-injector against the outer thigh. We will cover this in labs. But remember, never cover the end with your thumb. Always make sure you're aiming it the right direction because auto-injectors are a one-and-done device. So if you accidentally deploy it into your thumb, you get an amp of adrenaline and the patient gets nothing. Push the auto-injector firmly against the thigh and then hold it in place for 5 to 10 seconds. This allows time for the epinephrine to actually get into the muscle. You can do this through the pant leg, jeans. A heavy-duty canvas may be difficult for the needle to get through, so take that into consideration. And then after you remove the auto-injector, you would simply, yourself or the patient would massage the injection area for 10 to 20 seconds to make sure that that medication gets dispersed into the muscle. Because what happens when we do that, we're actually introducing a bubble of fluid inside that muscle, which is, number one, painful with that bubble because it's pushing the muscle apart. But also, if we don't massage it, that bubble just stays there for a longer period of time and it diffuses into the muscle over a longer period. So massaging it will get the medication into the system and working faster. Treatment for neurogenic shock. We want to keep the spine in a neutral position. When we're moving the patient, we want to be careful to support the head and neck. We don't want it flopping around, causing more injury. Always support the ABCs. Treat for our signs of symptoms of shock, temperature management, and then arrange for our prompt transport. Septic shock, same thing, ABCs. Treat for shock, keep temperature regulated, prompt transport. Internal hemorrhage, bleeding from the stomach or from stomach ulcers, ruptured blood vessels or tumors can cause some very serious internal bleeding and then shock. Patients with internal bleeding may exhibit coughing or vomiting of blood. Abdominal tenderness, rigidity, bruising, and distension to the abdomen. That's where their belly will kind of look a lot larger and it'll be more firm and rigid. They may have rectal bleeding, vaginal bleeding in women, and then they'll also present with the classic signs of shock as well. And remember, ABCs, temperature control, and that as well. So capillary bleeding is the most common type of external blood loss. Most of us do this to ourselves multiple days or multiple times a week, sometimes multiple times a day, depending on how much we are using and working with equipment outside or things of that nature. Venous bleeding is the second most common type. This bleeding has a steady flow and is easily controlled by direct pressure for at least 5 minutes. Sometimes even quicker. Sometimes it takes a little bit longer depending on the size. And then we have arterial bleeding. This is the uber-duper serious bleeding that we need to manage immediately. Arterial blood usually spurts or surges. If it is a retracted artery, it may appear to be an oozing type of bleeding, but it's typically a very bright red, oxygen-rich blood, and it comes quickly. So exerting direct pressure and maintain that pressure until EMS arrives. If you have a type of commercial tourniquet on you, apply that tourniquet. If you can't, or if you don't have one, you can make one out of a triangle bandage or some type of garment. I know this North Carolina Highway Patrol used to use their neckties as a tourniquet before they started supplying them with the commercially made ones. And then also remember to reassess that tourniquet as well. If you apply a tourniquet, the patient moves their leg or their arm or wherever that injury has occurred, it has the possibility of failing and beginning to hemorrhage again. If it does start to fail, you can try tightening it or placing a second tourniquet higher up on the limb. We never want to loosen it, and of course we don't want to put a tourniquet lower or over a joint. And remember, no tourniquets around the neck. That's not good. So some ways to help control external blood loss. Elevate the extremity while maintaining direct pressure to control external bleeding. While this does help, it's not really like the primary thing. It's covering it up and putting direct pressure is like the primary goal. Elevation does help with extremities. If the direct pressure does not stop external bleeding from an extremity, you can help elevate it then as you maintain direct pressure. If it soaks through your bandaging, just apply more bandaging on top of it to the point where it becomes ridiculous and you've got 2 feet of bandages, then you probably should, at that point, have used a tourniquet in the first place. There are times where venous hemorrhage, the use of a tourniquet is applicable in the event that there's that much vasculature that has been exposed that it's just more prudent to use a tourniquet to control that hemorrhage as opposed to direct pressure. So for direct pressure, we're going to apply a dry, sterile dressing directly on the wound and press it with a gloved hand, wrap the dressing snugly with a roller gauze, and then do not remove it after applying it. Why do we not want to remove it? Basically, we're taking all those clots and the scabs and we're ripping them off. And if anyone's ever pulled a scab off, we all know what happens as soon as you pull that scab off. Sometimes it actually bleeds worse than it did initially. Tourniquets should only be used on extremities and only on hemorrhages that cannot be controlled by direct pressure. So it doesn't necessarily have to be an arterial bleed. If you can't control that degloving or something like that with direct pressure, tourniquet can be used. There are hemostatic agents. They were developed by the military to provide rapid clotting if used properly. Usually they are impregnated gauze dressings that are supplied as a powder that you would actually shake onto the wound. The agents can be packed into a wound to rapidly aid in formation of a blood clot. They are useful for extremity wounds and junctional areas. This is anywhere like an armpit and the pelvis, places where you just can't get a tourniquet or it's difficult to actually get direct pressure and hold that direct pressure. So some communicable diseases such as hepatitis and HIV can be spread by contact with blood from an infected person. So we want to wear our nitrile gloves. We try to stay away from latex gloves because of allergies, but if that's all you got, better to use those than risk the potential exposure. Whenever you might come in contact with a patient's blood or body fluids. If you do get blood on your hands, wash it off as soon as possible with soap and water. And if you cannot wash your hands, at least use a waterless hand cleaning solution that contains an effective germ killing agent. So those pretty much everywhere that you go that has the hand sanitizer pumps that can work as a stop or as a temporary means of cleaning. You should still go find a sink, wash with soap and water, even if you do use those the hand sanitizers. Some communicable diseases such as hepatitis and HIV can be spread through contact with the blood of an infected person. So we should always wear our PPE or a BSI, wearing nitrile gloves or latex gloves whenever you might come in contact with a patient's blood or body fluids. Again, latex is less than ideal because of the latex allergies, but if that's all you have, when you're working in emergency services, BSI, such as gloves and masks, should not be hard to find. They should be in every vehicle. I personally carry a box in my own vehicle just for when responding in my local fire department's district. If you do get blood on your hands, don't freak out. Just go wash it off as soon as you can find a sink with soap and water. If you can't wash your hands off immediately, you can use the disinfectant hand wipes as a temporary solution and then wash your hands with soap and water later on down the road when you do find them. So a little bit about wounds. This is an injury that is typically caused by a physical means that leads to damage of a body part. So we have closed wounds. This is where the skin remains intact and unbroken. Only a closed wound is a bruise. An injury of soft tissue, which is beneath the skin. The small blood vessels are broken. The area becomes discolored and swells as the blood seeps into the tissue. And typically these bruises will heal quickly if they're minor. But also keep in mind that bruising and swelling may be a sign of an underlying fracture or a more serious injury within the skin. Open wounds. An open wound results from an actual break in the skin. This is typically when we see some kind of external trauma, whether it be hemorrhage or like in this picture you see like this abrasive type injury. Abrasions are also called scrapes, road rash, rug burn, what have you, and this occurs when there's a rubbing action from a rougher surface going across the skin. Punctures, this is where something actually is pushed into the skin. It occurs by not necessarily sharp objects, but something penetrates the skin. It may cause a deeper injury that is not immediately recognized by us from the outside. They don't necessarily or typically bleed heavily or freely from the outside. And an impaled object sticks out of the skin. And a gunshot wound is a special type of puncture wound if the impaled object has been removed prior to you getting there, not because you removed it. Then it is a penetrating wound, and as opposed to an impaled object. Lacerations are the most common type of open wound. We usually call it a cut. Minor lacerations may require little care, a little bit of direct pressure, maybe a Band-Aid or some kind of bandage. Larger lacerations can cause excessive bleeding and even be life-threatening because of the amount of vasculature that has been lacerated. Avulsions and amputations. An avulsion is where a piece of body tissue or segment is torn away. And then if it is removed completely from the body, that would be called a traumatic amputation. Amputated body parts should be located. In the event of an amputated leg, we need to find it, put it in a plastic bag, and store it somewhere in our ambulance so that it can't walk away on us. Keep it cool but not frozen. We want to avoid direct contact with ice. And then take it to the hospital to see if it can possibly be reattached. Minor bruisings typically don't really need much treatment, if any at all, but other closed wounds should be treated by applying ice and gentle compression and then elevating the injured part. Also remember, when we apply ice to the body or to an injury, we want to avoid direct contact with that ice. And then we want to splint any major contusions that we feel might have the possibility of a fracture or some other type of internal injury. And in the event of any hemorrhage, external hemorrhage, we want to stop that bleeding as quickly as we can using the cleanest dressings available. A lot of times in like your rural settings, you may not actually have access to a medical kit. So using a t-shirt or other piece of garment like that just to stop that hemorrhage in that event is better than waiting for somebody to show up with clean dressings. So dressings and bandages are applied to control bleeding, prevent further contamination or debris from getting into that injury site, to immobilize the injured area and prevent movement of impaled objects. Here's some examples of dressings down there in that lower left portion of your screen. We have, most commonly in our medical kits, you'll see 4x4s, 5x9s, and 10x30 trauma dressings. The 10x30 trauma dressings are rather large, and you don't really see a whole lot of those anymore, but there's usually a couple on an ambulance. The 5x9s or abdominal pads are one of the more common for your larger injury patterns. And then we have our 4x4s, and a lot of agencies will also use 2x2 dressings for your very little tiny injuries. If the bleeding does continue after applying compression and dressing, apply additional dressing on top of it. Keep holding pressure. If it keeps soaking through, just keep putting more on. And remember not to remove that base layer of dressing. If anyone's ever accidentally removed a scab from themselves, you should remember that it bleeds, and sometimes it causes it to bleed again, and sometimes will actually bleed more than the initial injury did. A bandage is used to hold the dressing in place, and that typical or more common types of bandages are roller gauze and triangular bandages. You'll see these in our jump bags and the cabinets on the ambulances. We want to ensure that the dressing completely covers the wound and then a little bit beyond the edges of the wound. Wrap it just tightly enough to control the hemorrhage or the bleeding, but not so tightly that we're restricting circulation from the body. And then also after we're done, we want to check the distal pulses or distal circulation to make sure that we have adequate tissue perfusion, and then secure it so that it cannot slip. Also keep in mind that as an injury swells, it can cause an increase of pressure or circulatory constriction, so we want to be mindful of that and continue to reassess. And always, when dealing with someone else's bodily fluids, remember to use your BSI when available. A relatively small laceration to the face or the scalp can result in a large amount of bleeding because of the amount of vasculature that is actually in these areas. They bleed a lot, and sometimes they can be a little bit difficult to control, but you can control most of them with just direct pressure. Direct pressure compresses the blood vessels up against the skull and stops bleeding. One thing we want to be careful of when we're doing this is to, in our assessment, make sure that we don't have any unstable portions of our skull where we could potentially have a depressed skull fracture. For wounds inside the mouth or in the cheek, you can provide some gauze that the patient can hold up against that injury, but also we want to be careful to not occlude the airway. In the event that we have a depressed or possible skull fracture, remember that there's a high probability of spinal column involvement as well. If any brain tissue or bone fragments are visible, we don't want to apply direct pressure to that. We would just loosely cover the dressing and secure it that way. Also, always maintain your patient's airway and breathing and protect the spine while doing so. Nosebleeds are pretty simple, cut and dry, because that's one of the things that causes them to bleed is dry air. But they can also be caused by high blood pressure or direct injury. We used to be told that you tilt your head back and pinch your nose. I think that came from the whole elevating the injury thing. That's actually not very good because it allows the blood to drain down the back of your throat into your stomach, causing nausea, possible vomiting, which will increase your blood pressure, which will make your nose bleed more, and then also get blood and vomit all over everything. So the best thing to do is to have the patient sit down, lean slightly forward, apply direct pressure right there at the top of the cartilage, and just hold that pressure. I find that supplying some Afrin spray or saline spray, a couple squirts in the nose, once you've gotten the major hemorrhage kind of controlled, helps reintroduce moisture into the nasal passages and will help stop that hemorrhage. Typically, you want to hold that pinch pressure for about 5 minutes, reassess. If it continues to bleed, go ahead and have the direct pressure again. If the nosebleed persists for a length of time, or judging on how much volume of blood they've lost, the patient may need to be transported to the hospital to have some more invasive procedures to stop that hemorrhage. When dealing with a lacerated eye, we want to cover that one eye with a dry gauze pad. It is also beneficial to cover the other eye just to prevent further irritation of that lacerated eye. Have the patient lay on their back. I find that actually turning the lights down, decreasing that external sensory noises and lights helps the patient relax. If there's a small foreign object in the eye, you can try to flush it with a saline flush. Usually you want to flush it away from the opposite eye. So let's say my right eye has something in it, tilt the head to the right and let the fluids drain away from my uninjured eye. Same goes with chemicals in the eyes. We want to flush it away from the unaffected eye. When we're dealing with impaled objects in the eyes, We want to place the patient on their back, cover the injured eye with a dressing or a paper cup so that we're not actually touching the impaled object. And once that's secured in place, cover the other eye. This prevents the patient from wanting to look around, and then also decrease those sensory factors as well. Minimize excessive noise, turn the lights down, slow movement will help reduce the patient's urge to move their eyes and look around. And then, of course, they will obviously have to be transported. You can't sign a waiver on these individuals and expect them to drive themselves to the hospital now. For neck wounds, really direct pressure with some bandaging. We can't put a tourniquet. We can't wrap the entire neck with roller gauze. In rare cases, you may actually have to just hold your fingers in place to prevent the hemorrhage from continuing. Major trauma also can affect the airway, so be on high alert for that. It can also involve neck fractures and spinal cord injuries as well. So patients with a chest injury, only a chest injury, we want to get them in a comfortable position. If the lung is punctured, air can escape from the lung, and the lung will eventually collapse. They may also cough up bright red blood as a result of that injury. But if there is an open chest wound, we want to cover that with an occlusive dressing. If you don't have occlusive dressings, you can use something like a sterile plastic wrapper from a bandage, or Ziploc baggies, or things like that. You can cover that wound up, and it allows the air or prevents the air from escaping. And then, of course, administer oxygen. Monitor your ABCs, treat the patient for shock. If they do go into cardiac arrest, perform CPR like you normally would. If they have experienced an increase in difficulty of breathing or labored effort, after you've sealed that wound, you can open the seal up to allow the pressure to equalize, and once it has, seal it back up. All right, impaled objects. Apply a stabilizing bulky dressing around the impaled object. Never remove the impaled object, because that's probably what's preventing massive internal hemorrhage, is the fact that that object is still there. If you do remove it, don't put it back in, because you're just going to cause more injury on reinsertion. So just take it in strides, fill out the paperwork, and hang on for the ride if you do pull something out. These people are obviously going to have to be transported to surgery. Sometimes an impaled object is too long to permit the patient to be transported, and special rescue or fire department will have to help stabilize that object and remove the excess portion by cutting it down. If the object is protruding from the abdomen, same thing, stabilize it in place, minimize or limit the movement as much as possible, prompt transport to the hospital for surgery. Blunt trauma, look for bruises and other marks on the abdomen whenever a patient experiences shock. There may be internal abdominal injuries as well. Place these patients on their back, elevate their legs if indicated by local protocol. Some local protocols are kind of taking that Trendelenburg position out of their protocols. Use blankets to conserve their body heat. A lot of agencies will carry these very large chemical heat packs called Ready Heats that you can provide some additional heat for patients that are in shock. If they're vomiting blood, it may be an indication it may be bleeding from the esophagus or the stomach. Have suction prepared, or be able to position them in a manner to allow that to drain from their airway. We don't want to give anything to the patient by mouth if they are vomiting. They also need prompt transport and reassessment of their vitals every 5 minutes. Open abdominal wounds, these can be usually are caused by a slashing of a knife or some other sharp object. They can also be caused by a puncture wound. One of my earliest experiences with this was a 12-year-old girl that was riding a bicycle that had the rubber handles had been removed from the bike. She hit a ditch. The handlebars turned sideways. She got impaled by the handlebar itself, and then she had exposed or protruding internal organs, intestines. But if they are protruding, we need to place the patient on their back with their knees bent slightly, and cover the area with a sterile dressing. We also want to make sure that that dressing is moist. If it's supposed to be wet, we want to keep it wet. Otherwise, if it's something other than that, a dry sterile dressing works, but especially for intestines and internal organs, we want to keep those wet. Utilize sterile water for that. Never ever attempt to poke them back in or push them back inside the body, because we will just cause further injury by doing that. Genital wounds, male and female genitals have a lot of rich blood supply. They're very vascular. So injury to these areas can result in severe bleeding. You'll need to apply direct pressure with a dry, sterile dressing. Although it may be embarrassing to examine a patient's genital area, you must do so to determine how severe the suspected injuries are and how you're going to actually bandage them and treat that. Extremity wounds. Apply dry, sterile compression dressings and bandage it securely in place. You can elevate the injury to decrease the blood flow and swelling. Splint all injured areas prior to transport because there may be an underlying fracture. Remember, we don't have x-ray. We are not doctors. We can't look at an arm and say that's not broken. Most deaths from gunshot wounds result from internal blood loss. The gunshot wounds to the trunk and neck can be a cause of spinal cord injury, so keep that in mind and protect the spinal injury or the spine when treating these patients. We need to make sure that we have an open patent airway and an adequate ventilation, assess for adequate circulation, control any excessive or external bleeding with our dressings and direct pressure. Examine the patient thoroughly for entrance and exit wounds. Now, we're not trained experts on gunshot injury patterns, so we just call them injuries. So if we don't call it a bullet entry wound and an exit wound, we would say I have 2 puncture wounds. We don't know if it's an in or out, but we're going to treat them both the same. And we want to cover both of those holes. Treat for symptoms of shock, temperature control, arrange for prompt transport, and of course, if they do go into cardiac arrest, we need to perform CPR as we normally would. Bites, these are pretty high, carry a high risk of infection. Patients should seek treatment for all bites. Minor bites can be washed with soap and water. They don't necessarily need transport by ambulance. With major bite wounds, control the bleeding, apply a dressing and a bandage. Our skin serves as a protective blanket that protects our body from outside substances from getting on the inside. It also keeps the moisture and other bodily fluids from going from the inside and escaping our body. When our skin is damaged, it can no longer perform these functions as effectively as it normally could. And the larger the damage, the more rapid or the more severe the loss of that function is. So we have superficial burns, which are known as first-degree burns. They are reddened and painful skin areas. You'll see this a lot with sunburn and other minor heat contact burns. Injury is confined to the outermost layers of the skin. The patient experiences some minor pain, moderate pain. Then we have partial thickness burns, formerly known as second-degree burns. They do not reach the deepest layers of skin, but they are partially through our skin. They commonly have blistering. There's some fluid loss and moderate pain, and they usually heal within about 2 to 3 weeks. Full thickness burns, this is where the burn actually goes all the way through our skin into our internal tissues. The pain is absent because where the nerve endings are, they've been destroyed, and they no longer can feel the pain. The pain actually comes in the healing process, is when the pain becomes more apparent. Patients lose a large amount of bodily fluids, and they are very susceptible to shock, hypothermia, and infection. So the rule of nines is a really good way for us to gauge the percentage of our patient's body that has actually been burned. You see on this picture here on the left, it gives you examples for infant, pediatric, and adult. The method for determining this method for determining the percentages is broken down into portions of the body by 9%. You'll see like the adult legs are 18%, so you have about 9 and 9 for the upper and the lower halves of the legs. The front and the back of the trunk and each leg equal to 18%. Your adult upper arms and the head are 9%. And then we modify it slightly for children. You'll see on a child or a pediatric, it's 12% for the head, 16.5% for the whole leg. And then we have also the genitalia is considered to be 1% for everyone, child and adults. So different types of burns are causes for burns. We have thermal. These are caused by heat. We want to place the burn in clean, cool water. Actually, we don't want to hold it in stagnant water. We want it to be more moving water. Because what happens if you put it in a bucket of cold water or a sink of cold water, and there's a lot of burning still happening on that burn, it'll actually create kind of a barrier, kind of like a wetsuit would, and it'll actually continue to burn. So if all you have is stagnant water, then you can probably maybe swirl the burn. If it's a hand, you can swirl it through the water. That way it's not staying stagnant. Well, once the burning is stopped, cover it with a dry, sterile dressing or a burn sheet. If there's blisters, we don't want to break those. Patients with large burns need to be treated for shock and transported to the hospital. Remember, when you have a large burn surface area of burns, you lose your ability to regulate your body temperature. We have respiratory burns. This is any part of the airway. Some of the signs and symptoms are burns around the face, the mouth, singed nose hairs, soot inside the mouth or the nose, pain upon breathing. If there's loss of consciousness as a result of fire, the breathing problems can develop rapidly or slowly. So even with somebody who says that they feel fine, keep a close eye on them because they could develop respiratory difficulty further down the road. Oxygen and prepare to perform CPR once these type of burns, airway burns, start to manifest. It can progress rapidly. And then, of course, as always, prompt transport to the hospital. So many strong substances can cause chemical burns. The longer the chemical remains in contact with the skin, the more damage it does, just like thermal burns and the heat. Initially, we want to remove as much chemical as possible. If it's a dry chemical, brush it away. We don't necessarily want to be washing it with water, especially if it's reactive to water. But you can also flush with water for at least 10 minutes. And when it says flush with water, it's a large volume of water, not just a trickle. Just in case that chemical does react with water, it needs to be a copious amount of water to flush. And then after that, we're going to cover it with dry, sterile dressing and transport the patient. Chemicals to the eyes can cause extreme and severe pain. Flush the eyes with water for at least 20 minutes. Hold the eye open and allow water to flow over its entire surface. and then loosely covered the injured eyes with gauze and bandages. And remember, if it's just one injured eye or one eye that's burned, go ahead and cover the opposite eye. If it is one eye, make sure that that one eye is on the downhill side so that we're not flushing those chemicals into the unaffected eye. Electrical burns. These occur when electrical current enters the body at one point and then travels through the body, tissue, and organs, and then exits at the point of ground contact. Electricity causes major internal damage that we cannot see from the outside. Patients may experience irregularities of cardiac rhythm, cardiac arrest, and ultimately die from it, or can die. Be certain that the patient is still not in contact with that current before you touch or treat them. Hitting somebody with a 2x4 does not work, or some other hard object. So we need properly trained personnel to be able to ensure that they are de-energized. And then, of course, monitor the ABCs of electrical burn patients and arrange for prompt transport with the internal burn patterns that could cause a very rapid airway occlusion as well. Multi-system trauma. This is an injury that affects more than one system of the body. So now we're not looking at just, oh, I broke my arm. Now we've got, I broke my femur, my tibia, my arm, and I also have a dislocated shoulder. Or we have multiple internal injuries as well. Several body systems may be involved. You may have internal and external injury patterns. So in summary, you must take appropriate standard precautions to prevent contact with our patient's bodily fluid. There are three parts of the circulatory system. We have the heart, which pumps the blood. We have the pipes, which carry the blood. And then we have the fluid, which is inside the pipes and the heart, which carries our oxygen and nutrients around and removes the excess waste. Three of the primary causes of shock are pump failure, pipe failure, and fluid loss. Three types of external blood loss that are possible. Capillary, this is where the blood oozes out. Venous blood loss is where it's a steady flow of blood, and then arterial, where the blood spurts or surges out. Most external bleeding can be controlled by applying direct pressure to the wound. A wound is an injury caused by any physical means that leads to damage of a body part. Wounds are classified as closed, and this is where the skin remains intact, or open, where the skin is open or disrupted. Open wounds are classified as abrasions, punctures, lacerations, avulsions, and amputations. And then we always want to control bleeding by applying direct pressure. You can elevate the extremity to see if you can decrease the blood pressure to that affected area, or apply a tourniquet if you cannot control the hemorrhage. Remember, you can use a tourniquet in venous bleeding, even if it's not an artery. If you can't control the bleeding, you can still use a tourniquet. Three classes of burns are distinguished based on depth. We have superficial, partial thickness, and full thickness. Burns may be caused by heat, chemicals, and electricity. All right. We have a few questions of review at the end of this chapter. Just remember, go back through your textbook, review the material, try to come up with a couple of questions for our review session at the beginning of the next lab day, so we can go through those as a group and discuss that together. And also don't forget that you have a quiz on this chapter once you've completed preparing for it. Up next, we have our three review questions. Question number 1. Which of the following statements regarding standard precautions is true? Which of those four options is it? The correct answer is A, standard precautions assume that all body fluids are potentially infectious. If we don't know, we don't know. So we want to err on the side of caution. Number 2, the appropriate management of an impaled object in the eye includes which of the following? The answer is bandaging both eyes. Bandaging both eyes prevents the movement of the uninjured eye to look around and see what's going on, which the injured eye would want to follow. Number 3, patients with full thickness burns generally do not complain of pain because of which of these following options? The correct answer is B. The nerve endings have been destroyed. They can no longer feel the pain. They will begin to feel the pain once the healing process begins.